Hello everyone. Today we'll discuss about Ryles tube insertion. It is also called as nasogastric tube. So this particular tube is inserted from the nose into the stomach. So this is also called as Ryles tube insertion. In this video, we'll see what is the definition of nasogastric tube, what is the technique that is used to insert a nasogastric tube, what are the indications and the contraindications of nasogastric tube, and which are the size, and how to identify whether it is in the proper place or not. So this we'll be discussing in this particular video. Starting with the definition. So this is a clear-cut definition. Nasogastric tube, a tube passing through the nose, pharynx and esophagus with a distal tip in the stomach for a variety of reasons including gastric emptying, drainage and feeding. So this is a tube that is inserted from the nose into the stomach for various reasons. So it may be for feeding or emptying or to drainage or to sometime to give medications. So this particular tube is used. So indication of this particular nasogastric drainage. So in ileus, following an abdomen surgery to prevent a regurgitation, to administer certain drugs into the stomach, such as activated charcoal in event of drug ingestion. And most of the time, if at all patient is not able to swallow, it may be in this particular situation, so person will be fitted with a nasogastric tube. So these are the indications of the nasogastric tube. So indications also, diagnosis of ingested substance, that is when it is unclear what patient has ingested. In such condition it is inserted. And enteral feeding in a patient with an endotracheal tube, in a patient who is unable to protect airway. So most oftenly what happens, if a patient is not able to swallow, there may be a chance that whatever the food or liquid that is taken from the mouth may enter into the trachea. So in such condition, there will be a chance that patient may develop a aspiration pneumonia. To prevent that, person will be kept on endotracheal tube as well as to protect the airway that should not be choked with the food materials. So in such condition, the nasogastric tube is inserted. So contraindication. So in coagulopathies, sinusitis, head trauma, esophageal surgery or stricture or deviated septum. In this condition, there may be a chance that it may cause a trauma to the system. For the same reason, it is contraindicated. So in the last video, we had seen the French size system for the urinary catheter. A similar size index is also identified for the nasogastric tube. Nasogastric tube comes in various sizes. It may be 8 French, 10, 12, 14, 16 or 18 French. So there are different variety of sizes of the nasogastric tubes. These are the stiff tubes that are easier to insert. So though it is stiff, it is flexible. Some fine bore tubes come with a guided wire to aid the placement. So nasogastric tube also comes with a guided wire inside that, so that's helpful for the insertion. The tube has a marking as well as and a radio opaque marker at the tip to check the position on X-ray. So at the tip of the nasogastric tube, the part which is inserted inside will have a radio opaque marker. So this is clearly visible on the X-ray, so that a person can identify that the tip of the nasogastric tube is in the proper position. So technique, when possibly identify more patent nasal passage by having patient sniff through each nasal passage. So if at all patient is conscious and he is able to take the commands, in such condition patient is asked to sniff through each nostril so that the patent nostril is identified. And after patent nostril is identified, then patient is made to lift his head up position. If at all the patient is unconscious, in such condition patient is made, put in the supine position and the nasogastric tube is inserted. Before the insertion of the nasogastric tube, it is to be it is to be lubricated, and then it is advanced into the nasogastric into the nose, aiming for the ear. As the tip of the tube passes into the nasopharynx, encourage or awake the patient if at all he is semi-conscious and ask him to swallow so that this can be facilitated into the esophagus and to prevent the entry of this particular nasogastric tube into the trachea. Most of the time, if at all patient is not able to take the command, it may need to put it with a much of the consciousness, say that it has to be very cautiously put into the esophagus or proceeded. It may be appropriate to have a patient to drink through straw during this procedure. So if at all patient is not conscious, this may not be helpful, but most of the time if at all patient is semi-conscious or conscious, in such condition, if you ask just the patient to swallow as you proceed with your nasogastric tube, then it will be helpful. Advance the tube to pre-measured depth. So you have to measure the stomach, this stomach from the anatomical position from the surface anatomy, and you have to measure how much it has to be proceeded. So once you proceed to that mark, then it has to be stopped. That is, the mid-gastric position over the surface anatomy has to be identified. Then the length has to be measured to what extent it has to be inserted into the stomach. Then it has to be stopped. Then you have to verify whether this particular nasogastric tube is in the position or not. By aspiration of the gastric content, audible of bubbling sound on auscultation, which is considered to be the oldest method, which is not used, which is not encouraged to use, and air injection or flat plate X-ray or the plain X-ray that is taken, which will show the radio opaque marker that is present at the tip of the nasogastric tube. Then secure the nasogastric tube to the nose with the tape. So this is the simplest procedure that can be identified. So we'll see what are the different ways to identify the whether it is in place or not. So verifying the correct intragastric position. The intragastric position of the tube must be confirmed after initial insertion, and this must be documented in the patient notes. So whatever the method that is used has to be documented there. So there are two methods usually recommended. One is pH test, that is the aspiration, so that we'll see what has to be done in the pH test, as well as the X-ray. Other methods can be inaccurate and should not be used. So this is what it is recommended. So either you go for a pH test or go for an X-ray to confirm. So pH test, the NG tube is aspirated and the contents are checked using a pH paper. Keep this in mind, not the litmus paper. So with a pH paper, it is checked for the pH. So the NPSA recommends that it is safe to feed patient, infant, children as well as adult if the pH is 5.5 or below. That means it is not the tracheal aspirated fluid, rather it is the gastric aspirated fluid. This advice does not apply to the neonates. So this should not be done in the neonates, preterm babies to 28 days. So otherwise 5.5 or below 5.5 pH, that is from the aspirated fluid, is considered to be ideal. Note that taking proton pump inhibitor or H2 receptor antagonist may alter the pH. Similarly, intake of milk can neutralize the acid. So in such condition, you have to be very cautious. If at all patient has taken the proton pump inhibitors as well as H2 receptor antagonist or the milk, so they may neutralize the acid. So there may be a pH which may be raised not below 5.5. So you may have to wait for some time so that whatever the action of the drug that should be reduced, or whatever the milk that is taken should be digested, and once it is you obtain the pH level that is 5.5 or below, then you can go with the nasogastric feeding. Next method is chest X-ray. When in doubt, it is best to practice to use X-ray to check the tube's location. So this is the best practice that is done, that is taking a plain X-ray to identify the location. Patient who has swallowing problem, confused patient, and those in ICU should all be given an X-ray to verify the tube in the intragastric position. So if at all patient is conscious and it is not a ICU, then it may be excluded, but most of the time it is advised to do this particular method. This involves taking a chest X-ray, including the upper half of the abdomen. The tip of the tube can be seen as a white radio-opaque line and should be below the diaphragm on the left side. So this is the position of the stomach. So the tip of the nasogastric tube should be in the stomach. Syringe test. So this test is here mentioned only for historic interest. So this should not be performed. Also known as whoosh test. It has been shown to be unreliable method of checking the tube placement, and the NPSC says that it must no longer be used. So let me just mention what is the whoosh test. So after insertion of the nasogastric tube, empty syringe is taken, the piston is withdrawn, and it is connected to the nasogastric tube, and it is pushed. And on the surface of the abdomen, stethoscope is placed and heard for the whoosh sound. So if you identify the whoosh sound, say that it is in the position, proper position. So that is syringe test. The complication. So there are some of the complications while insertion of the nasogastric tube or after insertion of the nasogastric tube. One is epistaxis, perforation of cribriform plate. So if at all the push is so strong that it may also do the perforation. Then esophageal perforation. Tracheal intubation with NG tube can also cause pneumothorax. So these are some of the complications. Moving on to clinical pearls and pitfalls. So nasogastric tube should be very well lubricated to prevent mucosal aberration. So lubrication is a must. So lubrication has to be done properly, then it has to be inserted. Patient should be able to speak following a placement. If unable, nasogastric tube may be between vocal cords. In unconscious patient, tube insertion may be guided with the fingers, laryngoscope or laryngeal manipulation. So if at all the aid of the laryngoscope is needed, then laryngoscopy can also be used. Do not tape tube too tightly to the nose to prevent alar injury. So it should not be too tight or it should not be too loose so that it can come out. So it has to be adequately placed in a position. So these are some of the information regarding Ryles tube or nasogastric tube insertion. So in this video we have seen that the definition, the types, the indication of the nasogastric tube, the contraindications, the techniques by which it has to be inserted, the methods to make sure that the nasogastric tube is in the position. Then you have the pitfalls and pearls of nasogastric tube, so and the complication. So these are covered in this particular video. Thank you.